Call the Joint Committee on Health and Human Resources to order. Short a quorum right now, so we'll skip past our next agenda item for the minutes. We'll go into our presentations portion of our agenda. First up today, we have a discussion of OB services, and we have Jeff Good, the Executive Vice President of Vandalia Health, and Dr. Aliff, as well as Becky Harless. If they'd come up to the podium, please. I'll have to swear you all in, sorry. So if you all could raise your right hand. You swear the testimony you give will be the truth, whole truth, and nothing but the truth, so help you God? Thank you very much, appreciate it. You guys can come up one at a time if you want to the podium, however you want to do it, fine.
Good afternoon, everybody, and thank you for the opportunity to come speak at this session regarding OB care in the state of West Virginia. In my role as an Executive Vice President with Vandalia Health, I oversee a portfolio of our regional hospitals in West Virginia, many of which are rural. And I'll give you an outline of our journey to now with regards to building a rural healthcare network within Vandalia. And then I'll turn it over to Rebecca Harless, who's our administrator at the Greenbrier Valley Medical Center, who has been very acutely working through this situation. And then we're privileged to have Dr. Dara Aliff with us today, who is a practicing private practice OBGYN physician in the Charleston area. She also trained in our residency programs at CMC and continues to participate in the education of our future OBGYNs in the state of West Virginia. So Vandalia Health was formed in September of 2022 with the merger of CAMC Health System and Mon Health System. We brought in Davis Health System after that, and Greenbrier Valley Medical Center was added in January of 23. Today, Vandalia Health has 17 hospitals which are owned and operated by the company, 3 hospital affiliates, and more than 200 outpatient locations across West Virginia. We employ over 14,000 people. We have more than 2,000 providers, and we have 70 plus specialties that we cover our hospitals with. Our footprint in West Virginia runs from Princeton to Morgantown and from Parkersburg to Elkins. And as I noted, many of our locations, such as Webster County, Broadus, those are rural areas within West Virginia. Vandalia Health's mission is to improve the health of our communities through excellence in clinical care, one patient at a time. That's a mission we take very, very seriously, especially when we're considering the programs and services that we try to offer, sustain, and grow when capable within the rural areas of West Virginia. If you break it down to a little bit of a more personal level, we're trying to preserve and strengthen healthcare in West Virginia. We're trying to expand access to specialty and tertiary care. We're trying to improve the coordination of care across our hospitals, our clinics, and our physicians. And we're trying to create an economy of scale that supports our rural and community hospitals. Many of you, I'm sure, can appreciate the difference between an urban hospital and a rural hospital. And Becky will certainly go into some of those issues more for you as we go forward. The key to this is continuous investment in our workforce, our education system, our ability to innovate and apply technology across the state. A few examples of innovation and technology, for example, was connecting emergency rooms in rural areas to emergency rooms in urban areas so that we move information instead of moving patients. So if you keep that in mind as we go through the conversation. We're committed to building a West Virginia-rooted healthcare system with the goal of keeping care as close to home as possible. The recent reorganization of our company really is putting the spotlight on all of our hospitals outside of Charleston, and we continue to work more and more with the local communities we're in, especially workforce development, the local high schools, the local community colleges, and the small colleges around the state. I'm going to touch just a little bit as I segue into having Becky come up. Greenbrier County, as a county within West Virginia, has seen a population decline in the past 5 years. The county, despite some, I guess, kind of views from above, it's an older population in the Greenbrier service area. Median age is 46.8, and nearly 26% of the residents are 65 or older. The subset of women in childbearing years is no different. There is some population decline in that area. And the number of deliveries alone is not triggering whether we offer an OB program directly or not. The one message that's really important is if we're able to have doctors, if we're able to have nurses, and we're able to have safe outcomes, those are the biggest reasons why we'll offer care or cannot offer care. We cannot put efforts into sub-optimized staffing levels or sub-optimized providers and put people at risk. Many of our patients show up in rural areas, oftentimes into their second trimester already. So the absence of prenatal care, the comorbid conditions of patients that show up with multiple health issues require a higher level of care, even in your rural areas. And Dr. Aliff will speak to that as well. So with that, I'll turn the microphone over to Rebecca Harless.
Thanks, Jeff. As Jeff said, my name is Becky Harless. I'm the Chief Administrative Officer at Greenbrier Valley Medical Center. And Vandalia Health acquired Greenbrier Valley Medical Center in January of 2023. I was given this job July of 2023. So I'm going to go through and kind of give you some of the numbers from my experience at Greenbrier Valley Medical Center. We serve 4 counties as our main service area. It's Greenbrier, Monroe, Pocahontas, and Summers. Our population there is about 63,000. About 32,000 of those are women. What we've seen in the population decline, as Jeff talked about, a population decline overall. But when you look at ages 20 to 34, so if you look at ages of childbearing or going to be childbearing in the next several years, there's a drop of 4.9% in 20 to 34-year-olds, and even more alarming, in 15 to 19-year-olds, there's a 10.7, almost 11% drop in the population. Deliveries, as you can see, from 2019, we had 2015, I think we had over 500 deliveries. In 2019, 456 to 2025, 261. That's a 43% drop in deliveries. So that's just kind of a generic look at the population. When you look into the provider side and the nursing side, we had 3 physicians as we came in there. 2 of them left, so that left 1 provider who frequently, I went back in the car today and looked at how many days she took call. She took call 20 to 24 days on average a month. And that's not easy call. That's not just call, come to a surgery and go home. A lot of times that's sit in your office and wait for a very long time. So those not easy call days. One left for personal reasons and just a way of life and to stay home with their kids. And another one left to move to Charleston, which highlights some of the difficulties with recruitment in a rural area. During the time from my tenure here, from July of 2023, actually 2024 to 2026, we had 7 different locum tenens or per diem physicians that would assist us and help in those 6 days or 8 days that our physician wasn't on call. So we were bringing people in just simply to give her a break, let her go out of town for a little while, be with her family. We had 14 of our employed nurses leave. So 14 employed nurses left. We had 22 different travel nurses that would rotate in to keep the service covered. So when we look at how we recruited physicians, we have a local group in Vandalia, an employee group that helps us recruit, but we also went outside and pulled down a company to help us try and recruit physicians. We had ads out on national, across the nation for OBGYNs. We had, in one of those ads called Practice Link, we had 1,800 views of our job and 1,044 passive candidate outlooks. And then another one, we had over 1,100 views. All of that got us 10 interviews. So we had 10 interviews in that period of time. We made 9 offers and we didn't get. Now, what we did, there's a question there about, so is your pay competitive? The company came back to us and said, you have to pay here. So we went back through our committees and got the pay up to where it needed to be. And that was the pay that we were offering. So we had 10 candidates. We made 9 offers. There was one just, wasn't right for us or them, and weren't able to secure anyone. And with that, I'll hand it over to Dr. Aliff.
Hi, I'm so honored to be able to talk to you guys today. My name is Dara Aliff. I am a board-certified OBGYN. I was born, educated, raised in West Virginia, Boone County, and have been practicing in Charleston for the last 20 years. I am the co-founder of the Premier Women's Health Specialist practice that my husband and I work in. And I'm currently the chair of the West Virginia section of the American College of Obstetricians and Gynecologists. So I'm here, I want to go over basically 5 data points, hopefully to kind of give a national anchor to what we're seeing here. And as you all are aware, the access to rural care is a crisis that is here and now, and it's not just in West Virginia. I don't want to sound doom and gloom. I do have some really positive things that I hope to stress also. The main thing, though, the number that should give everybody pause is the birthing unit closures nationwide. There have been 116 since 2020, and 27 of those closures were last year alone. That is the biggest acceleration that we've seen in OBGYN or in OB closures. Only 41% of rural U.S. hospitals will have labor and delivery units and currently have them. The Center for Healthcare Quality and Payment Reform said in December of 2024 that access to rural maternity care is in a, quote, state of crisis, and more women and babies will die unnecessarily until it is resolved. West Virginia specifically, more than 2/3 of our rural hospitals no longer offer obstetric services. That places us among the worst in the United States. The perinatal partnership maps really demonstrate that when you look from 2006 to 2025, and there are just hollowed out areas of the state with access to rural care. Southern and eastern West Virginia are experiencing the biggest brunt of that, with many of the women driving over an hour to the nearest birthing facility. A decade ago in West Virginia, we had 26 hospitals offering L&D, and now we're down to 18. So when a unit closes, I think it's important for us to remember, women don't just stop giving birth. They have them in ERs, they have them on the side of the road, they have them at home, and many of them will die. The human consequence also is a lot of these women are traveling out of state. In 2023 alone, 2,188 women traveled out of state for obstetrical care just because it was closer and easier access. Now, a broader picture, and what we talked about a little bit for Greenbrier County, is just the decline of our population. The numbers are dwindling. In West Virginia, our births have declined from 2013 to 2023 at a rate about 3,500 per year. So people are choosing not to have, or we're not attracting the population to the state that is in childbearing age, and the ones who are likely opting to go somewhere where they feel they have closer access to care. Our population overall has declined by 4.3% over the past decade, while nationally the population is rising about 6.2%. So we currently rank about, the last I looked, 50th in population growth. The declining birth rate looks at a broader thing. It's not just a statistic. It's an economic signal. These are fewer babies being born, fewer students in our schools, the workforce is smaller, and it tells us whether or not people of childbearing age feel safe coming here to start their family. There's also the implication, and the third point I want to talk about is the maternal mortality and outcomes data. We had 102 maternal deaths between 2019 and 2023. This is all from the Perinatal Partnerships data. Overdose was the #1 cause, so we know that our opioid crisis and the maternal health crisis are linked. So we are tied right now with overdose deaths are tied at 36 with all other maternal health conditions combined. The preterm birth rate in West Virginia is 13%. We're the third highest in the nation. 12% of the very low birth weight babies that were born in non-tertiary care hospitals had no prenatal care at all, not even one visit. And that's from a WVU Berkeley study that was done from 2020 to 2022. So in 2025, in April, ACOG came up with a new path for prenatal care to specifically address this, talking about mobile health units, group prenatal care, which has been shown to improve outcomes, and access to telehealth. We have some ideas about all of that, and we just need the infrastructure to deliver it. The OBGYN work shortage is a problem nationally. I want to stress that. There's really nothing that Greenbrier Valley could have done differently with what we have to work with right now. In West Virginia in 2018, when we thought we were really flush, we had 280 OBGYNs, and we were already 20 short of what we were projected to need. By 2030, we will have a need for about 240 and only have 200. Our workforce is aging. A lot of the OBGYNs in the state are aging and retiring, and there's no one moving along to replace them. Nationally, though, OBGYN supply is projected to fall 10.3% by 2037, while the demand rises 2.7%. We're expected to only have 86 OBs for every 100 needed. So the overall, we know that there are lots of contributing factors. Some of those we can address. I think there is a multi-pronged solution that we could all get into. I'm happy to share those ideas later, but it's mainly creating clinical, legal, and financial incentives for doctors to stay here or want to come here in the first place. The fifth point I want to talk about, and this is the most important thing that I can talk about today because I'm so excited about it, and it's the transforming maternal health care access. As you all know, in January 2025, CMS designated West Virginia as one of 15 states to receive about $17 million in funds over the next 10 years to transform Medicaid maternal care delivery. So pre-implementation period is now, as you guys know. And so now it is important to identify the delivery partners and accelerate that. We have until 2027, but I think if we can get some partners identified and roll out care before that, that would be amazing. What it could cover are mobile prenatal care units, group sessions, community health worker workforce, health-related social needs screening, telehealth integration, and rural access partnerships. We know that this is, to me, this is the exciting part. I've told you all the doom and gloom. I think this is the exciting part. We have the funds. The federal government has indicated confidence in us as a state to be one of 15 to be offered this money. Now we just need to act. We need leadership and action. The women and the pregnant women in McDowell County and Pocahontas County and all the rural areas are watching right now. There are definite things that this legislature can do, and I personally think that this will be the single most valuable thing that you could accomplish in your time in state government. We can lead and create a new replicable model that other states can follow, and people can say, well, look what they did in West Virginia instead of look what West Virginia did wrong. This is our opportunity. I know you guys are excited about it. I'm really excited about it. I hope that conveys, and I'm happy to talk to any of you about it privately, here, anytime. I'm really excited about the opportunity. And I thank you so much for your time and for letting me talk to you today.
Thank you very much. Appreciate it. Before we get to questions, move back to agenda item now that we do have a quorum. So I look to the co-chair to make a motion.
I move the minutes from the meeting held January 12, 2026 be approved.
You've heard the motion from the co-chair. All those in favor say aye. Opposed, no. The ayes have it. Declare the motion adopted. All right. With that said, we'll go back to questions for our presenters. If you would just call their names, you have Dr. Aliff, Ms. Harless, and Mr. Good. Any questions for our presenters? Delegate from the 54th.
Thank you, Mr. Chairman, and thank you all for your presentation. Dr. Aliff, you work in, for recruiting doctors to West Virginia?
I do not. Well, I should say, I currently own my private practice. We have tried to recruit doctors to come and run who want to own a private practice, but that's just not going so well. It's hard to get OBs to come to the state.
Okay, maybe the answer is very good.
I'll add a little bit. That I have been heavily involved in physician recruitment at CAMC for years. And as an organization, we typically would recruit 50 to close to 100 physicians a year into West Virginia, and we've continued to do that. But certain specialties are just getting harder and harder, and OB is one of them. There's a practitioner, a physician out in Greenbrier County that actually told us his daughter is an OB, but she will not stay out in the Lewisburg area because she's across the border in Virginia in a group that I think has 7 OBs. So she's 1 in 7 versus 1 in 2 in terms of taking call. So as Becky noted, we have put in a very big effort to bring OB to West Virginia, but we've not been able to get over the bridge on that at this point.
So that specific specialty, it's harder to recruit in West Virginia. Have you seen it, has it become harder since 2022?
I think so. I think prior to COVID, going into, say, 2016, it seemed to me, as somebody who employed doctors, a lot of the movement from physicians who no longer wanted to be in private practice for all the business and economic reasons of running a private practice, all that seemed to slow down. But then we went into COVID. And then coming out of COVID, there's been a whole other rush of physicians in private practice that generally just want to become hospital employed now. And so we've been through another round of that. But there are certain specialties, hematology, oncology, cardiology, OBGYN, GI, they are getting harder as someone who's recruited physicians for 20 years.
I guess the point I was trying to make over 4 years ago, of course, the state passed a very restrictive law on those who practice that profession. I was asking if that made it even more difficult. So if they could practice in Virginia or Maryland or other states bordering us whose legislature doesn't tell them how to practice, does that make it more difficult to bring OBGYNs to West Virginia?
I think when an OB today's OB will check us out through all the online means and through their social networks and through their educational networks, and the state of West Virginia paints a picture when they log in. And I think there are several kind of socioeconomic factors that are making it a little harder for us to get OBs in this state. There's no doubt. Yeah. The other thing I would like to say is CAMC, now Vandalia Health, we have an OBGYN training program. We've had a core residency program since its inception in 1972, and it continues to educate residents. And Dr. Aliff is very involved as one of the faculty members with that. And as a whole, we kept 70% of our residents in the state of West Virginia last year, not just working at Vandalia, just working all over the place. So we are doubling down on our commitment to educate physicians in West Virginia because we want to keep them here once we train them.
Thank you.
Yeah, delegate from Montgomery County.
Thank you. Thank you for being here. I have a question. When you talked about you had 10 candidates, none offers, no sign-ons. Were there any specific reasons, like maybe the top 3 or 4, as to why they did not agree to sign on that maybe we could address?
Yeah, it typically came down to the number of people in the practice. So it was tremendously overwhelmingly a call issue. As Jeff mentioned, that we do have a physician who's actually on our med exec whose daughter is an OBGYN. And actually one of these candidates was a local candidate. She lived in Renwick, grew up in Renwick, West Virginia. And I called her after the fact and said, just friendly, can we talk and help me understand why you chose somewhere else? And she was going to be 1 in 8 call. So it's a lifestyle, and as we're talking about too, the group coming through has been taught to really prioritize life and family, over work. And so, they come to work. The group that's retiring, just did all the work. They worked all the days. They did 24 call days. And the group coming up really doesn't want to do that. They want to have, a home life as well. That was really tremendously overwhelmingly the reasoning.
Okay, and one more question. And you said that you lost 14 RNs and you had 22 travel RNs to cover. So with retainment, and you alluded to keeping some of the residents in West Virginia that were trained here, those that you are retaining in West Virginia, what percentage of those are going to rural West Virginia?
I don't have that statistic right in front of me right now, but the majority of the kids will take jobs either in, I would say probably a third, if I was to make a quick glance, because when you look at WVU Medicine, Vandalia, and Marshall Health, you have the 3 biggest employers in the state, and all of those entities will hire our residents. We also populate residents in some of the community hospitals, but I would say it would not be more than a third.
Because that's one of the top issues that we continually hear is recruitment to rural areas. Like, they talk about a lot of barriers, but my concern is, are they being recruited or desire to go there now before we look at any other means of trying to increase recruitment? Because if it's not working now.
Yeah, I've seen the universities do more rural track residencies as well as the CMC training programs. We're all focused on trying to select kids from rural areas, support kids from rural areas, get them back to their rural areas. And this goes with nurses, lab techs, radiology techs, everybody who's in a community college, because it takes a village of these people to run a hospital. But you definitely need doctors and advanced practice providers. And as you know, OB nurses are specially trained. So,
Thank you.
you're welcome.
The senator from Cabell.
Thank you. You mentioned we're short and we're losing more. Does the certificate of need impact that lack of having more OBGYN doctors?
I'll answer. We'll probably all answer from a perspective. I don't see CON being an issue with regards to being able to recruit OBGYN doctors. I just don't.
But if there was from my understanding of it, if there was an opportunity for someone to want to come in and start their own business, their own practice, doesn't that certificate of need prevent them from doing that?
Well, would you look at right now why OBGYNs are choosing to practice where they are? I mean, there was the question about the overall legislative environment. I think that's part of it. I think that's where we fail to get out of state people, because people who live here know what we are about. That, what I feel like we're missing in recruitment is that a lot of the workforce now in our field is women. The majority of people graduating are women. So I think they're willing to work, but they can't outsource maternity leave. They can't outsource things like that. So where I feel like we're maybe missing the mark is to think outside the box. We talk about community support. We all know that we have it. We know what West Virginians are about. If you're trying to get people from out of state, I think where hospital systems would succeed is way back in the day, they had things like daycares. I grew up in the basement of Memorial Hospital. While my mom was a nurse, there was a daycare. So if she got overtime or whatever, we just stayed in our little daycare and did our thing. And I know that that's fraught with other issues too, but it doesn't have to be the hospital. If people moving to a town, specifically in this case women, because that's the majority of that workforce, I think if we offered things like that, we recognize what we're going to need from you. So here's what we're willing to offer in return. That's what does it. Right now, I think you'd be hard pressed to find OBGYNs who are like, I want to go out in the middle of nowhere and start a birthing unit, because they're not going to want to do that. They don't have the support, the community support, and that's what we are good at. So when I say I'm excited, those are the types of things I think we need to do. There are definite things that have been proven to improve recruitment that we can do in this state, and we can probably do it better than anybody else. So I think those are the opportunities that we have personally.
I don't disagree with that at all, but I think at this point where we're in such a desperate need, anything would help for the recruitment. And I just look at a certificate of need as being one of those obstacles that maybe would be something where someone would look at West Virginia and say, yeah, I'd like to go there, even if it was in a more urban setting that would still flood West Virginia with more of the doctors that are needed. But with that, I don't think a lot of people look at West Virginia now because they know that that is an obstacle for setting up a business in West Virginia, whether it be Huntington, Morgantown, Charleston, or rurally. So I'm just wondering about that. That was my question. Thank you.
I've got a couple questions real quick, then I'll go to the delegate from 64th. We're talking a lot about workforce, and I get that, but you said you were chair of ACOG for West Virginia chapter. Is there some sort of threshold, or what designates an OB unit as delivering enough babies a year? Is there some sort of threshold that says what's low volume or what's high,
That depends on a lot of things,
Okay.
like in terms of the economics of the county and state that you're in. But we do know that if we don't have parity in terms of our government payers, right now in West Virginia, I think we're at like 72% in terms of Medicaid reimbursement. So when you have that decreased number, and in states that are, or in counties that are reliant more on government payers, I think achieving parity with other states, surrounding states, is going to be key. If you can't, of the majority of hospital, I wish I had the number in front of me. I just had that last night on the tip of my tongue. But the majority of current OBGYN units in rural America, not just in West Virginia, are operating at a loss, almost all of them.
Mm-hmm.
So those reimbursement rates are key to keeping open the units that we all have nationally and here, I think.
I think, Ms. Harless, you gave a data point that said, I think, 261 babies at Greenbrier Valley in 2025. Is that correct?
That's correct.
So, Dr. Aliff, when you hear that number, is that a thriving OB unit? I mean, from where you see other hospitals, what are other hospitals doing compared to that number?
Oh gosh, well, right now at Women and Children's, because of the closures, there are days you walk on our floor and we are bursting at the seams. But no, that's hard to staff a full-time unit when you're looking at maybe less than a baby a day.
Do you know, and maybe not, maybe Mr. Good, do you know what CAMC does on an annual basis delivering babies?
Vandalia, a chart for Vandalia Health last year showed 4,000 babies across the Vandalia footprint. I think, remember, ideally, if 3 OBs or a couple of OBs and a couple of midwives can be located in a town to give you 24/7 coverage, and you have anesthesia there to give you coverage in case you need a C-section, and you can keep 3 shifts of 24/7 nurses that are OB trained, it boils down to how many babies. The more the better, because it's like any other kind of program. The more you're doing, the more touches you're doing, the better you are at it, the better you're working as a team. If you start dipping down around 200 or so deliveries, you're now talking about a 24/7 operation that's really not active every day. And if on top of that, you get into the more complex economics of, are these all Medicaid or underinsured people? And remember, in rural areas, you're often paying premium dollars to get your providers out in the rural areas than you are in the urban areas. And COVID was a great example that showed everybody in the industry, if you've got young doctors out in rural areas and the patients aren't flowing throughout the system from rural areas to tertiary areas and back, it's a tremendous amount of pressure on these young physicians if they don't have kind of senior physicians around them. We were just talking about this as we came in of young OB doctors if they're out in rural areas. So, for example, some of the things we're doing out at Greenbrier Valley, we've worked with the local ambulance service out there. So we've got more ambulance on site at the hospital. We have telemedicine connections from the ER at Greenbrier into the ER at Women and Children's and to the NICU at Women and Children's. We've worked with HealthNet to put a newer model helicopter out there with bigger helipad. And our ED doctors are going back through all their training with regards to stabilization and delivery of OB patients. So we're creating a whole new system of care to make sure that, and probably the even bigger issue, and we've heard this a couple times in here, many times in rural areas, expectant mothers are not showing up for their first OB visit until they're into their second trimester. So we're trying to shift out into the communities so that we can identify all the pregnant mothers and start to kind of triage those people from a risk perspective so that there are no surprises walking into the emergency rooms.
Thank you. I appreciate you answering my questions. A delegate from the 64th, Delegate Burkhammer.
Thank you, Mr. Chairman. And I want to just kind of piggyback off of that last couple of statements you made there about prenatal care. So we already are seeing a shortage of it, it sounds. How are we going to continue prenatal care in the community? What does that delivery system look like for Greenbrier or for Lewis County or any of the others?
Thank you for that question. So Dr. Perkins is our OB-GYN at Greenbrier Valley, and she has decided to stay on and provide GYN care and prenatal care. So what that looks like is a conjoined effort with Raleigh General, with Princeton, and with CAMC Women's and Children's, with those providers to say, you can get your prenatal care here through a certain time frame. And that looks, it's not uniform per patient because different things pop up. There's a lot of comorbidities. So that's an individual plan per patient. And then they choose where they want to deliver, whether that's Raleigh General or CAMC or Princeton. And they choose where they want to deliver, and then that care is transferred to an OB-GYN at that time.
Delegate, Becky's been working with Ms. Songer at Stonewall, so everything we're doing at Greenbrier, we're transferring her learning to those up in the Weston area so that we can improve the system. And again, I think from a physician perspective, that there is nothing that stops physicians from forming a private practice and coming in and opening a business. And as a hospital, if we have a robust OB-GYN group, we're going to do everything we can do to keep an OB unit open. But when you get to the standpoint of not having that consistent professional level of service and you start to have risk go up, you're doing a much better thing by identifying early and getting that person to a higher level of care.
Yeah, so I want to, great segue into the next question is, so Dr. Aliff, are you a private practice, but then in a partnership and you deliver at CAMC, or what's that look like?
I'm in private practice. I can deliver anywhere. I have delivered at Thomas and CAMC. The majority of my deliveries and surgeries are at CAMC.
And what do you think the hindrance is of private practice setting up in some of these areas that are losing, OB and then partnering with the hospital? Because I feel like our current delivery system is hospital-based, and you would somewhat be an outlier to that, or are there others like you?
There aren't many left. And for full transparency, we are currently looking at contracts right now to be acquired. It's harder and harder to do. Reimbursements are going down. Instead of the other way, the cost of malpractice is going up. There are very real things we could do to change that in this state. So it's getting almost impossible, but we are at the point we could keep going like this till retirement, but we can't find anybody that wants to run a private practice when we retire. So, it makes sense. We've had full support from all the hospital systems. I think we learn from them and they learn from us and what's happening out there in the private practice world and how to best support. And I can say that universally, everybody's been really good about that. I haven't had any pushback about that. And that's why the CON question threw me, because even when we started a private practice, I didn't need one for private practice. That wasn't part of what I needed to do. So I don't think that applies to us.
Yeah, I think you're right on that on the CON aspect, it's not, OB is not under that purview. So just to kind of bring all that together, you don't think it's a reality to have private practices and try to recruit those folks into our communities and to meet that need?
I would love it if we could do that. I just think right now with the rate of reimbursement from federal payers, they would not be able to keep the lights on. I think it would be almost impossible. And that's a national trend. That's not a criticism of our state. If you look right at this point, almost, 70 to 80% of residents are now leaving and going straight into an employed model. They're just not out there. Private practices, for better or worse, and I feel like worse in a lot of ways, are just not happening. That's not the trend.
Thank you, Mr. Chairman.
The delegate from the 26th, Delegate Rohrbach.
Boy, Dr. Aliff, you just set up a perfect segue for this question. 40 years ago when I went into practice, I went to the bank, took out a large loan. My wife did too. She's a practitioner as well. You recruit physicians, all of you. So I'd like to hear from all of you. Is it realistic? Do you see anybody in the model now that goes that, because I recruit physicians as well. Are you seeing anybody that wants to go to the bank on top of the loans they've already acquired for school, living expenses through school, all of that want to go out and borrow $500,000 to get started? Because that's probably the kind of money you're talking. Would that be a fair model to get a year's cash flow to get started? Are you seeing anybody wants to do that right now?
No, and I think at this point, at least for OBGYN, even $500,000 would be under. I mean, the hardening of the insurance market right now and what's happening to our medical malpractice insurance rates, we're inching closer to the St. Paul situation where it's next to impossible. The amount you would have to make to pay your malpractice premiums. Now, they'll be lower right out of residency, as you know, you don't have that tail risk. But I think that's almost an insurmountable thing. It would probably be millions to try to get something going.
For the benefit of the committee, could you say what the rough first year premium out, because as people probably know, the premium goes up over 4 or 5 years till you reach maturity. But what is a clean claim first year obstetrician out of residency or fellowship going to be expected to pay in West Virginia first year?
I look back wistfully. It's the good old days. It's like 20,000 versus like 100,000 a year now.
Yeah, that's what I thought. That's the kind of money we're talking here, folks. Now, but I'm going to ask a couple other questions. As far as Vandalia, how many hospitals do you have in West Virginia?
There's 14 hospitals, and in 3 we manage.
Okay. That's 17. How many are you doing obstetrics at?
So I'll list them out for you. So at Women and Children's Hospital, at Davis Memorial, and at Mon General.
So you're only doing obstetrics at 3 out of 17 facilities. And I would assume, and your footprint's pretty big, it's all over the state. I would assume that in large part is because financially, it's just can't, with the volume you've got in some of these rural hospitals, it's just not going to happen financially that you can support the $1 million to get somebody started in practice. Is that a fair statement?
That's a fair statement. You know, a hospital operates all the programs and services that you provide. Some pay for others, some are subsidized. It all goes into the big pot. When you're in a small environment like that, the OB subsidy starts to become very heavy on a rural hospital.
Yeah. Now, that's a good segue to the next question, last question. The Rural Health Transformation Program. As you talked about, the expenses are extreme, and I doubt if people haven't really lived a medical practice, I don't think they can understand the cost. Do you see any help through the various programs and the pillars of the Rural Health Transformation Program that the Morrissey administration has set up? Some of that, is that going to be helpful in this particular situation?
That's a good question. Initially, there was a lot of exuberance around the $199 million coming a year. There was some, and I'm speaking in general terms, there was some skepticism as to whether or not any of that money would actually get down to the meaningful provider community hospital level. For example, many of our hospitals need boilers and chillers and roof replacement and a lot of those things. As the first tranches are starting to come out and we're making applications, there was, the one for workforce development. That seemed to be well designed, and we made multiple applications from Vandalia across workforce because that workforce bucket went from your entry-level workers all the way up through your professional people. The one about telemedicine, we've already got a significant investment in telemedicine. We see telemedicine as being integral in terms of moving information instead of the patient. So we are seeing some benefit. But if you're asking me, is it going to put a provider into a rural community? I don't see that path just yet.
Okay. Thank you, Mr. Chairman.
Thank you, Ms. Harless, Dr. Aliff, Mr. Good. Thank you very much for being here and speaking to us and educating us. Thank you very much. Move on to our next presenters for an educational discussion on family support centers. First, we have April Miller, the Executive Director from Tucker County Resource Network, Sandra Mason, the Director from the Tucker County Family Support Center, and Audrey Morris, the Executive Director from Morgan County Family Support Center. If they would please come up to the podium. Did you get them all? Thank you for being here. If you would all raise your right hand, I swear you in. Do you swear the testimony you give be the truth, the whole truth, and nothing but the truth, so help you God? Thank you very much. Whoever wants to come up first and speak, appreciate it.
Good afternoon, everyone. I'd like to welcome you to Tucker County. I'm April Miller. I'm the Executive Director of the Tucker County Family Resource Network. And I'm actually honored to be here. We don't often get a chance to speak to you all as a group. We speak to you individually, but speaking as a group, this is a little new for me. I saw many of you at the National Youth Science Academy yesterday, I think, when you did the tour. Yeah. And they're a big partner of ours. Today, the main topic is family support centers. That's where the funding issues, as far as we know them, come in. But we thought it was important to talk about family resource networks as well, because they're important to this discussion, and I think some clarity needs to be made around family resource networks and family support centers and how they operate. Because often people confuse the two programs, and it's an honest mistake to make because we're so blended. We work together in tandem, basically, with each other. But they're through different funding streams. The FRN and FSC are through multiple funding streams, but two different grant sources. But again, we go hand in hand with each other. We complement each other in our efforts. The FRN is a planning and coordination grant. It's designed to bring people together, identify needs, and find solutions to those needs in a community as the people that live there see it, like from real experiences from people. I'll give you a little background because this is a 30-year history. We have a 30-year history here in West Virginia, FRNs and family support centers. In 1994, the Governor's Cabinet on Children and Families was created, and from there was some small implementation grants that were awarded to communities in 3 phases. And the idea was setting grassroots initiatives, bringing people together to talk about what's going on in the community. What does your community look like? What do you need to do? What do you need to do to make it look better? How do you come together? So at that time, I was actually a young mother at that time. I won't give away how young I was, but I had a 3-year-old son. I worked at a local health clinic here, the St. George Medical Clinic. And the director there came to me and says, hey, there's this new thing called Family Resource Networks. Can you come and share your knowledge about, your life as a young parent? And I'm like, well, sure, I'm more than happy to give my opinion and my insight on things. So I participated in a 3-day, it was a retreat at YMCA Camp Horseshoe here in Tucker County. And there was about 20 to 25 of us, parents, grandparents, community leaders, faith-based organizations, just represented people that live in the county and experience our county. And we came together and we talked about what are the barriers that exist? Like, what do you live with every day? What's it like to raise a child here or have an elderly aging parent here? Like all the things. So we came together, brainstormed, talked about our strengths, talked about the weaknesses, talked about potential, that is in all communities in West Virginia. And so we spent that entire weekend together, just discussing what we wanted Tucker County to look like. And you need to keep in mind that this was happening in other counties all over the state. At that time, I'm not sure how many in that first and second wave, but there was at least 14 or 15 things happening like this at the same time. And when we left that session, we had a vision of our community, like a pie in the sky, literal vision of what we wanted. We wanted strong family support systems. We wanted childcare for working families. We wanted safe parks, safe communities. We wanted our kids to be able to participate outside and families to come together and solve problems. That was our vision. We literally wanted everything. We wanted everything when we came out of there. Like, we had this great vision. So when we got out of that session, we hit the ground running. And again, that same process is taking place across the entire state. By 1996, there was 47 active FRNs. So they rolled out in about 3 phases, I think, if I remember correctly. And all of them look different because they were community-led, community-driven. Like, what's happening in the Ohio River Valley is not the same thing as happening in the mountain counties. You can see the differences as you drive through here. So we all have different things that we need to address. So in 1996, the Tucker County Family Resource Network became a 501c3. We got our first grant, big grant, through the Governor's Cabinet on Children and Families. It was $50,000 back then. And we got to work. Like, we started working with the school board, and we worked on universal pre-K with Head Start. We all came together. We started the foundation of a child care center, which was a big priority for all of us. And we realized quickly that the vision that we had, that big, broad vision that we had, you couldn't fund it on 50 grand, right? Like, we had a lot of things we wanted to do. So we learned very quickly about how to grant write and how to fundraise, how to pull resources together that were available in the community and share things so we could go farther with our money. If there's anything about a family resource network and a family support center, is we are nothing if not efficient with our money. We can stretch a dollar about as far as it will go, because we collaborate and we work together to make things happen in a community. So today there are 45 FRNs that cover, I think, 52 counties. There's several multi-county FRNs now that are more regional. We employ over 200 people. Currently today, where we started with the $50,000 grant, today we are funded at $38,600 a year for this planning grant. And the FRN funding is designated as a line item in the state budget. And I think it's around 1.8 million. Don't quote me on that, but I think it's in that ballpark. So I think you all probably received the infographic. I see some of you have this green sheet here. I won't read it for you, but I mean, it kind of shows the, we weren't the only ones wanting to do everything, because last year alone, the FRNs leveraged around $18 million in additional funding that went directly into the communities. We logged 136,000 volunteer hours, and I think that's probably a conservative number because that's a really hard number to track. And we raised or attained $8.25 million in in-kind resources. And in-kind can be anything from diapers to food to clothes for kids in the winter, rent, if you offset rent, when you partner with another agency and you share resources, people's time and energy, that's all that in-kind number there. So that's kind of what we do. I'll use the FRN as an example because there's a lot of confusion around family resource networks and family support centers. Our family resource network here in Tucker County, when we were incorporated, we became the Tucker County Family Resource Network Incorporated. And under that, we have a Family Resource Network grant, which is the planning and coordination grant, the $38,000. We have the Family Support Center grant under that as well, which does the outreach, the direct service, the heavy lift, you know, the people things. We have and it actually started in 1998 with a Starting Points program grant. That if anybody's ever heard of Starting Points programs, that is now what the Family Support Centers are. And they began in 97, 98. We also have an in-home family education program. So we really stayed true to our original mission of early childhood education and family support programming. But the confusion sometimes happens here with this because not all FRNs and FRCs are set up this way. I think there's 12 FRNs that house there's 12 FRNs and FRCs that are, or FSCs that are under the same umbrella. But then some have their own nonprofits, or they're under a community action, or they're under an education program or a healthcare center, things like that. So they look very different across the state. And we don't all have the same priorities because this is not a cookie cutter approach to life, because we all know that the cookie cutter approach it doesn't work because a rural community is very different than an urban one. Some communities have a lot of resources, rural communities generally don't. So whereas our ability to decide what to do in our community, it's a blessing, but it can also be a curse to try to explain to everybody how we do things and how to keep those things separate so they make sense to people. But most FRNs and FSCs, regardless, I call them FRCs because we were called that before, just a couple years ago, but most all the FRNs and FSCs, regardless of if they're under the same roof or not, work together collaboratively. We work collaboratively with the Board of Ed, with healthcare, Team for West Virginia Children's a big partner of ours. And so we all work together to meet the needs of communities. And so FRNs really kind of strengthen, and FSCs strengthen the fabric of resources in West Virginia. We know things are pulled tight and, you know, kind of, it's hard to cover a whole state with social services. But the family resource networks and the family support centers keep things together, keep those resources connected, and with the ultimate goal of keeping families, keeping kids out of the system. That is our ultimate goal, is successful, healthy families that don't have to rely on a system. That's our goal. That's what we want to do. So FRNs and FRCs, I'll just wrap this up because Audrey's doing the important talking here, but we're quite literally the community we represent. We're the people, we're West Virginians, we're the community members, and that's driving this car. We work together to build strong families and communities. And I wanted to say that that's why I'm here today, to remind you all that I'm really grateful that you and your predecessors for the past 3 decades have invested in West Virginia, in real people. Every year you've invested in us, and we really appreciate that. And it's really important to keep us because the need keeps growing every year exponentially. It seems like the need gets a little greater, but we're doing great things. We have great plans, and we hope to keep doing this for another 30 years. I don't want to do this for 30 years, but more years, but you know, it's important, it's an investment, and you all have made that possible, and we really do appreciate it. And I will turn this over to Audrey.
Good afternoon, I'm Audrey Morris. I'm with Morgan County Starting Points Family Support Center, and we were one of the originals. We came in 1999. So The starting points came from the Carnegie Foundation, who did a nationwide study back in the 90s that proved that families needed a place to start. And the starting point centers and the family support centers and family resource centers came up across the country. So we are a network across the entire country of family resource and family support centers. We're not funded through all of that national money, but we do network with the other states. So West Virginia started with 7 pilot centers. I think Marla and Charlotte were some of the pilot centers back in the early mid-90s. Then there was an expansion. April and I came in the late 90s. And then again in 2013-ish, there was a little bit more money thrown in and about 5 or 6 more centers were funded. And then in 2022, centers were funded in every county in the state. And if any of you've been around for a little while, you remember former West Virginia Senator Charles Trump. And he once said, if you've seen a family support center, you've seen one family support center. Because as April said, we're all different. You may see the piece of paper that's our statement of works and things, I know what those people do, but you come to our county and you say, well, in Nicholas County, we have a daycare center, but in Morgan County, you don't have a daycare center. No, we worked with our school system to help them get with their pre-K program. Once that was established in the school systems, they didn't need that anymore. And so we backed out of that. We filled the gap while it was needed, but then we backed out when that gap was no longer there. So that's an important piece, as April kept talking, that we're all different. So we are set up different. We in Morgan County were under the Shenandoah Valley Medical System for 22 years. And we got a divorce from them about in 2024. It was amicable, so it was all good. And we became our own 501c3. Part of the reason that we separated from them was because we had grown exponentially in our programming, but also in our funds. So our $250,000 grant that we get from the state of West Virginia, we have tripled that through other grants and other donations in our county. If that was gone, that other money would also be gone. But we are community-based, and we are driven by the family's needs. We provide and adapt evidence-based programs to meet evolving community needs. We're continuously working to help families reach self-sufficiency and reduce their need for long-term public support. There was upstream, people talk about upstream, so they kept pulling families out of the river and someone finally went upstream to find out why they were in the river. That's kind of where we are trying to be, is upstream, so that those families don't fall in. But if they do, we want to also be downstream supporting them to get them back out and back into their community. We're designed to help families be stabilized before that crisis is reached and they end up in the CPS system. So we have talked, and it's kind of in the back of my head a little bit, that we want to emphasize that our programs are from pregnancy to age 18, and that any family can come into our program and receive services. We have worked with families who have master's degrees because they had a need for child development education, and they came to us to participate in programming so that they could be, taking care of their family. This was a family who could financially afford to have a private person help them, but they were sitting right along others in the community that may have been involved in a CPS case. They were all getting the same information and the same support. That master's degree family may not have needed free diapers or free food or whatever, but they were getting the same educational components. So we include families in a holistic approach to overcoming challenges, building social connections, and promoting the safety, permanency, and well-being of children and families. We are safe gathering places for families to socialize, receive services, and collaborate with others. And unlike DOHS, families can visit our centers multiple times for all kinds of different programs. So they may have a preschooler, they may have a middle schooler, they can still come in and get services from us, providing activities and different opportunities. When I say services, I don't always mean free things. Services are education and other opportunities. So we do parenting education classes. We have trained facilitators to, with nationally certified evidence-based programs where families can receive one-on-one parenting if they need that, or in groups. Child development activities where families come together and participate in activities where the families are there together, but we have a facilitator who's trained to kind of oversee and make sure that parents are not doing peer things and giving bad advice to each other. We want to make sure that they're getting the right kind of parenting knowledge. We had a parent in one of our play groups a few years ago, and our facilitator noticed that the 2-year-old wasn't really talking the way they should have been. And so we were instrumental in getting referrals to West Virginia Birth to 3, where that child was screened and was found out the child was deaf. So we were able to help them get to the West Virginia School for the Deaf and Blind and get services for that child. We provide linkages to home family education through funding with Team for West Virginia Children, and linkage to health programs to provide access to primary care, including developmental screenings and information for health programs for adults. We all know that in West Virginia, public transportation is an issue. So in many of our counties, we have one primary location. In Morgan County, that location is in Berkeley Springs. However, in 2023, we opened a small outreach site in Paw Paw, which is 25 miles or 30 miles from anywhere. If you have ever been up our way, if you're in Paw Paw, you're not getting anywhere for about 40 minutes. I went to Webster Springs to visit Charlotte. And I jokingly said when I got there, I need McDonald's or something because I need a Pepsi. And she said, sweetheart, you missed that about 40 miles ago. So that's kind of where Paw Paw and many of our smaller locations are. If you need a service, if I don't have transportation, I can't get there. You can have all the great things in Berkeley Springs that you want, but if I don't have a way to get there, it doesn't help my family. So many of us go out, we either have actual outreach sites in other parts of the county, or we go there certain days of the week to provide services. And our Paw Paw location, the Early Head Start comes there and they provide programming for their families who are enrolled in Early Head Start, but they use our center to do that. They can't afford to have another site there, but through community support, we have been able to provide that extra center. We have a dad that we were working with. He was unfortunately in a CPS case. He was doing parenting education with our facilitator. We have a fatherhood program that is a dad who is specifically providing fatherhood programming. And so this dad was working with both of them, but he's in Paw Paw. And so he wanted to get his GED. He graduated, got all of his stuff, got his kids back. He started a GED program in our center through Spokes. He was with that for 6 months, and he now has a job. He has his kids back, he has a job, he's functioning in his community, and in large part because of services that he received at our site. When families come to us, when we were talking to people about coming here and addressing you guys today, they kept saying, don't talk about free stuff, don't talk about giving out free things, because they just don't want to hear about giving out free things. But you know what? Free things are important sometimes. Because if I'm a single mom or I'm a family and my husband lost his job or I lost my job, we just lost our income, but our bills are staying the same. And we need some free stuff until we can get employment and get back to where we are. Because our bills aren't going to stop. We don't want to lose our home or our cars while we're looking for other employment. So sometimes going somewhere and getting free food, free diapers, free wipes, free clothes until we get back up on our feet, that's important. Because I'm not being stressed about those basic need things. I can focus on becoming self-sufficient again. And having those basic needs, I'm less likely to abuse or neglect my child because it's all intertwined. When I'm stressed, they're stressed. And we all know that child abuse happens. So, sorry. Mobility mentoring and goal setting is a big thing that's come through. We've always done it a little bit, but it's become a large component of what we're offering families. So while we're giving away those free things and we're providing them, social and emotional programming, we're also providing life skills education. we do budgeting, we do financial literacy, and we do some of that in our school system as well as we do with adults. So we're doing, I talked about adult education, tutoring, literacy, instruction, job and career readiness, training and services. We have an employee who started with us several years ago when her children were just babies, and she was coming to one of our play groups. We were talking last week about how we're promoting our family support center in our community, and she said, you know, I didn't think about it before, but I was coming to your play group when my kids were little. And when my husband went to get a new job, I came to Starting Points to get help with a job resume for him and to help him look for employment. And then my kids are seeing you in the school system with literacy programs and nutrition programs. And I said, yep, and now you work for us. So that's where many people, many employees in our centers have come up through our programming and are now employees of ours. Cooking and nutrition classes, because we all know that obesity, diabetes, heart disease are big things. So many of us do nutrition programs in our counties. We do a program called Cheap Eats. So we take the dollar store. Everybody has that Golden Arches and then the other Golden Arches in your county, you know, McDonald's and the dollar store, because we all have both. So we have, there's curriculum online that you can pull down on the dollar store. It gives you how to make this meal, what ingredients you need, how much it costs, and all of the dietary needs and nutrition needs to that. So we're doing that with our families. We're taking those ingredients, we're going to them, we're making the meal, we're eating it together, we're talking about it, and then we're giving those ingredients to take home so that they can replicate that meal. We started a new project just last week, Farm to Table. So we're doing CSMs with a local farmer. He's bringing us the food. We're cooking the food. The family is helping to prepare and cook that meal. They're eating it together, and then those families take their own CSM home. So they're taking that fresh produce home with them to prepare that meal at home. We also do parent support groups such as Circle of Parents. And again, I talked about the fatherhood program. We collaborate with our schools and our community partners for after-school programs, academic enrichment, adolescent pregnancy prevention and mentoring programs, and team support groups. We're providing connections to mental health and substance use disorder programs and enriched recovery support. One of the new projects that many of us, and we're thinking there's about 17 counties in the state that are working with the court improvement program through the West Virginia Supreme Court for something called a Parent Resource Navigator. And the Parent Resource Navigators, we were the pilot program in Morgan County. We worked with Cindy Largent Hill, and we were going, our judge is sending us families who have needs, and we're not really sure what we're supposed to do with them. And so we came together with our judge, Deborah McLaughlin, and we created this Parent Resource Navigator. And so when families are coming through that CPS system, there isn't really anyone to advocate and help them. So our Parent Resource Navigators, the 17 counties that are existing and the 8 more that are being onboarded, we have a specific person who is meeting that family and those parents to help them reach their improvement plan and to gain reunification. The reason that Cindy really wanted this to be in the family support centers was because when they were reunited with their family, with their children, she wanted them to have that support in their community that's not going to go away because they would still qualify for family support center services. We promote the 5 protective factors, which most people know that the conditions in the community and the family, when they're present, they increase the health and well-being of children and families. And these are attributes that buffer helping parents who might otherwise be at risk for abusing their children. So we've talked about money, we've talked about services. The $250,000 that we receive, in some counties, that's what they operate on. They're probably newer, they're the ones who were funded in 2022, but most of us that have been around for a while, like I said, we have increased our budgets exponentially, and we do that through community support. We write grants like crazy. I think I wrote 6 grants in about a week and a half Some were $1,000, some were $25,000, but that was money that we were able to pull into our county to provide programs such as summer camps and literacy programs in our schools. So we're working with corporate donors in our communities. The additional funds support those other activities. In 2025, 35,000 individual family support service engagements were conducted in your 57 FSCs in West Virginia. And again, as April said, this has been a 30-year commitment from our legislators and our state government, and we appreciate that. If that funding goes away, you are going to see an immediate impact in your communities. There are centers that have already lost employees. There are centers who are already cutting back on the services they're providing. And across the state, we have 230 employees in your FSCs, over 30 AmeriCorps members. We hired 4 AmeriCorps members just for the summer. So we're employing college students for the summer to help with our programs. And then we have hundreds of volunteers. Those volunteers frequently come back to be board members. They frequently become supporters financially, which again increases our capacity to provide more family involvement. In closing, DOHS, I still want to say DHHR, I can't get that out of my brain. They may be where families go for a crisis, but the FSC is their next step and where they receive ongoing support to move to gaining economic stability, self-sufficiency, and maintaining strong families. Thank you all.
Thank you.
Good afternoon. I'm Sandra Mason. I'm the director of the Tucker County Family Support Center. So I get to kind of wrap up what they said. So I get to do some of the impact stories. So picture it, Sicily, 19, whatever. No, just kidding. So what we do all of these things, and the relationships are what I value the most. The relationships that we build with our community members, the relationship that we build with our families. One of the impact stories I want to share with you, if I don't choke up a little bit, we have Healthy Grand Families. If you guys are familiar with our Healthy Grand Families, I have a lot of grandparents raising grandchildren in West Virginia. So we do work with Healthy Grand Families, and we had a gentleman come through our program. So we always like to follow up. So one day I was passing by his house and I stopped, and he was sitting on the porch, and I went in to kind of just follow up with him, and I'm like, hey, how's it going? He said, well, he had tears in his eyes, and I'm like, oh my gosh, did I come in a bad time? And he said, my granddaughter was just life flighted to Chestnut Ridge. She tried to commit suicide. My heart dropped, so I sat down on his porch, and he's like, I got CPS coming tomorrow and all these things. And he was so overwhelmed, he didn't know what he was going to do. So I told him just to take a breath. We'd work this out. We had lots of resources for him. So actually Chestnut Ridge called while they were there. They were talking about medications, and I'm like, well, you might want to ask these questions. So then when we went back, and with his permission, I said, can I share this information with people that we work with? So we contacted with the Board of Education, kind of got them on board. So we were able to help him get health resources to mental health. We were able to work with the granddaughter when she come home. She was able to get into our Empower You program, which is one of the things that we got from Audrey in Morgan County. So we go into middle school kids in 6th through 8th grade, and we work with teaching them empowerment things, teaching them how to be more self-sufficient. So we worked with the juvenile, because she was on probation when she got home. So we got to work with probation. So she's doing community service. She just served a free meal with me the other night as part of her community service. So without Healthy Grand Families, I wouldn't have stopped that night on his porch, and we had this conversation. So, and that's kind of where we're at. He felt comfortable with us because he went through our program. A lot of times if I come and sit on your porch and say, how you doing? You don't want to tell me your troubles. You're going to say fine, and I'm going to leave. And that's good, because now I don't have to do anything to help his family. but he felt comfortable enough saying, hey, I don't know what to do. My granddaughter's at Chestnut Ridge. I didn't know if she was going to live last night. So that's the relationships that we build with families. They just don't come in for a free meal or come in for those diapers. We build a relationship with these families. We let them know that we're going to be there in a crisis. We have our circle of parents, which we love. We have lots of programming. We have other things where families have shared. A young lady in one of our programs lost her husband to suicide. And that support group was her outlet. She got to meet with them every week, and she got to be able to talk to someone else. So those are the things, is building those relationships. April's worked for 30 years in our community building relationships. We have a strong relationship with our Board of Education. We have a strong relationship with our 911 center and our local police officers. I'm laying in bed one night at 10:30 at night, and I get a call, and it's one of our local officers, and I'm like, oh my God, what did my kid do now? What am I going to do? He's like, hey, we just had a traffic stop. We've got a family that's got 2 kids that aren't in car seats. Don't know what to do. 911 gave us your number. I went down to our pantry, picked up 2 car seats, went to the Shop and Save where they had them pulled over, so we were able to provide car seats for the family. So we are first responders in our community. When there's a disaster, when COVID hit, the health department was calling, hey, I got a family that needs food. Can you drop food off at their door? These are the things that our family support centers offer. A teacher calls from one day from school and says, hey, I got a kid that's got his shoes duct taped together, and he's not wanting to do anything because he doesn't want to get up from his desk because he's got duct tape on his shoes. Within a half hour, we were at the store, new shoes, to the school, got a text back from the teacher going, you just don't know what you just did. And to you guys, it's a simple pair of shoes, but to this child, it was everything that day. It was more self-confidence. It was more being able to learn for the day. So I'm not sitting there worried about my shoes. I'm able to pay attention. So again, just to say that family support centers, we're all different. Maybe these impact stories that I'm telling you is from my community. Everybody sitting back there has the same stories, if not more. I know they've shared some throughout the time, but if you do reach out to your family support center, go visit them, see what they have to offer, let them tell you those stories, and you'll get the same impact stories that I'm telling you. And the 5 protective factors, again, I'll tell you one more story. We have a circle of parents, and it's a support group for parents. They look different in every county. Had a foster family. Our parents as teachers, actually. When I was a home visitor before I had this job, I was her home visitor, and she had just adopted 4 babies under 3 years old. Like, she had a house full. And our parents as teachers did a spa night as a recruitment thing. So I was kind of telling her about it, and she looked at me and she said, what about parents that can't have babies? Is there a spa night for us, people that adopt? So anyway, that's kind of where our circle of parents started is, I'm like, oh, okay, let's do it, a spa night for adoptive families. And she started our support group. Had a young lady in our community that was asked to join our group all the time, and she had just been through recovery. She was, I think, a year sober at the time, but people were reaching out and saying, hey, why don't you join our support group? She's like, well, I'm not a parent. I lost my kid. I lost my kid to the court because of my addiction. But she said, I'm trying to get my child back. And I'm like, well, that doesn't mean that you're still not a parent. Just because you're not with her doesn't mean that you can't parent her. So she didn't feel comfortable joining our circle of parents, but she said, I have a really good idea. Can I start a circle of parents? So we got her trained in circle of parents, and now she's leading it's what's called Parented Interrupted, and it's for families with addiction, or if somebody that has lost, you don't have your parent in your care right now. And she does that because she's lived it and she knows it. And we just supported her in getting this circle of parents off the ground. So we do many, many things, and every county looks different, but we do. Again, Lauren, thank you guys for allowing us to speak today. Please reach out to your FRNs or your family support centers, find out what they do. You guys could be a resource for us too, and send families our way. So again, thank you guys.
Thank you. Are there questions for our presenters? Any questions for our presenters? The delegate from the 64th, Delegate Burkhammer.
Thank you, Mr. Chairman, and thank you guys for all the information and handouts and things. So I wanted to get specific on two items, but in 2022 is when you were able to launch statewide and received better funding. And so since 2022, there's been a downward trend in CPS referrals. Just roughly, I think it was about 7,000 or a little bit more in 2022. And we're down below 6,000 as of today, about 5,900. Do you think there's a direct correlation in the work that family support centers are doing in the community, helping families in that number? And then if family support centers go away, do you think there will be a rise in CPS referrals and CPS involvement?
Of course, we want to say yes.
Will you use your mic, please? There we
Sorry.
go.
Of course, we want to say yes. We want to take that credit for that. Part of that, I would say, and Jim McKay is here with Team for West Virginia Children, so if you really want an answer that's scientific, ask Jim afterward. But we also do education in our communities. So we are working with community partners to provide education. So I won't say, oh, yes, we did it, it was all us. But I would like to think that, yes, there are more of us. We're more connected to the community and providing more education. And if we go away, I would hate to say that there is the potential for more abuse happening because those services aren't there for families. But really, if you want anything in those, ask Jim. He's in the back of the room.
Well, yeah, thank you for that. So I'm going to switch gears really quick. And it says on your one handout, every $1 invested in FSCs returns up to $4.93. Can you speak to how that return is coming?
I think the return is coming through other funding leveraged. And I think they include grants that are written that expand upon our program or that create new programming, donations, the in-kind matches that we have applied to each dollar of the grant received. So most FSCs and FRNs too have to leverage more money to get things done as far as programming. So that it's just it's a match according to how much funding was brought in by the agencies. We probably all have those numbers specific to our own county too. That was just a lump sum that was brought together for this infographic.
I think the handout kind of talks a little bit different, and I'll
I don't have
yield out, but it just talks about for every dollar invested, it reduces child welfare involvement, crisis intervention, stronger families, and those things. So I was just curious of how they were directing not the additional funding that was coming in, but how it was actually
Reducing the
returned.
need
Yeah,
for
but-
those services.
But I'll follow up with you. I'll yield. I know we're getting close on time, so thank you, Mr. Chairman.
Delegate from the 54th, Delegate Pushkin.
Thank you, Mr. Chairman. I want to thank our guests, familiar with the work that so many of these centers do. In full disclosure, I serve on the board for one, and you're right, they're all very different in what they do regarding what region they're in or what, the communities they serve. And it's true, you're doing the work that's keeping children out of an already overburdened system. My question is not for you, my question is for the governor's office. Is there anybody from the governor's office here with us today?
Sir, we're just having the presenters in front of us.
Okay, well, and I'll address you, Mr. Chairman. We passed a budget where they're funded, so how can the chief executive come out then and say that funding is being reduced after we've already passed a budget that he signed?
Sir, I'm not aware of any funding being reduced for this next fiscal year. But that's an appropriate question for the administration for yourself, but I don't have that information.
Thank you.
Further questions? Yep. Senator, sorry, I apologize. Senator.
Thank you, Mr. Chairman. Thank you all for your presentations today. I think one of the things that stuck with me most, Ms. Morse, was about the long-term public support is what you're trying to keep people out of. and that you're trying to really face these situations that keep people from falling in a hole. You mentioned $250,000 as an approximate amount about how much, I think, in TANF funding that you all would get. If that funding went away, how many of these 50-some family support centers would be able to continue doing the work that they do? Would there be ones that would have to close?
So the grant, specific grant amount that we all get, every county, is $250,000. So we all get the same, it is the same amount. I don't know how many are closing, but I know that in Tucker County, they've already lost 2 employees who left because they were afraid of budget cuts. So whether or not the governor or whoever has said they were going to cut our budgets, the fear is, and the anxiety is already in communities. And as we were meeting outside, there were centers who were already talking about laying off people and closing doors.
So you're talking about an instability that this has created.
Correct.
One other question is, you both talked, Ms. Miller too, about you guys have been doing this for 20, 30 years.
We're
You
old.
Did not mean it in that regard. You all
older
have
than
lots
April.
of experience. I'm sure a lot of what I've understand that you do is very much evidence-based practices for which you have to be trained.
Correct.
Which experience really matters in connecting people.
Correct.
And so if that funding even drops for a little bit and you lose some of those people, how does that affect the quality of services that the communities can expect?
We would have to hire other people who potentially wouldn't have that skill set. We would not be able to fund those or continue those programs. So if we talk about like the PRN program, we have 3 educators with the nurturing parenting, so it's an evidence-based curriculum. We have 3 people trained to do that. That's an $800 training per person. So if they left, like we'd have to have $800 to train 1 new person. So we've talked about among us as far as the people in our centers who are trained in multiple curriculums that we're providing not just to our families, but we're providing that curricula to schools, to police departments, to agencies. And if they go away, then those trainings and that education are also leaving the state potentially. In my case, I'm in Morgan County. People jump across the line to Maryland all the time. So there's a lot at stake for being lost to the state if that money is decreased or it goes away.
Thank you. Thank you, Mr. Chairman.
Further questions for our presenters? Seeing none, Ms. Miller, Ms. Mason, Ms. Morris, thank you very much for being here and educating us, taking our questions. Thank you very much. Is there further business to come before the committee? Seeing none, I look to the co-chair for a motion.
I move that we adjourn.
Co-chair moves we adjourn. All those in favor say aye. Opposed, no. The ayes have it. Declare the motion adopted and meeting adjourned.